Alrighty, today we are going to be talking about the cardiac system. This is going to be exam 3, essay 1. Today we are going to start by focusing on cardiac muscle, the different types. There is 2 types of cardiac muscle that we're going to be talking about today. We are also going to talk about the difference between the SA and the AV node and the role that they have in muscle contraction. Next, we're going to talk about action potentials. Because there are two different types of cardiac muscle, there's going to be 2 different types of action potentials that we see because the cardiac muscle is different in the heart. So we're going to be talking about that. We're going to be talking about ECGs, or also referred to as EKGs, is another way you might hear them. In EKGs, we're going to be talking about a couple different types of irregularities called NSTEMI and STEMI. These are identifiers for background heart issues, background current issues that we see on these EKGs that help us identify different types of infarctions. We're going to talk about 2 different mechanisms, and so this is going to be related to the sympathetic, which would be increased heart rate, and then the parasympathetic, which would be decreased heart rate. So we're going to talk about, we're going to talk about those 2 different mechanisms of increasing and decreasing heart rate. We're going to talk about calcium and how calcium affects the heart contraction, and how calcium plays a role in cardiac cells, and how it's a little bit different from muscle cells. And then lastly, we're going to talk about the left ventricle, specifically, especially in our class, our focuses. We're going to be talking specifically about the left ventricle. We're going to talk about the aorta. We're going to talk about different cycles that we see the aorta go through, and how that changes blood volume, how that changes blood pressure. And then we're going to talk about the valves and the sounds and how those correlate with the different cycles of the heart. Alrighty, so let's begin. Let's begin by going over very briefly, and that's a horrible heart. So this is a rough diagram of the heart here. Those are our ventricles, those are our atriums, and these are our ventricles right here. On this side of the heart, on the right, so this is going to be the right side, and this is the left side of the heart. On this side, we're going to have our tricuspid valve, and on this side, we're going to have our bicuspid valve. We'll talk a little bit more about those in the future. We have the aorta that stems from this side of the heart. We're going to have our superior and inferior vena cava. My Apple Pencil has been super weird, so might have to redraw something because it's not getting good signal. Anyway, these superior and inferior vena cava both feed into this the right atrium of the heart, and then into the right ventricle, of course, and then we have that goes out into the pulmonary trunk, which goes out to our lungs. We'll call these our lungs. Anyway. And then obviously the venous return is going to come into the right atrium, through the bicuspid valve, into the left atrium, into the left ventricle, and then from the left ventricle out through our aorta into the rest of the body. Now, something important to note here is in between the aorta, so right here in between the aorta, and then also from the inferior vena cava, the inferior and superior vena cava, into let's see, sorry. Oh yeah, so we have a semilunar valve here. It's going to kind of have these 3 flaps like this. And then we are also going to have a semilunar valve that is part of our return. So it's going to come from like these pulmonary veins. So we're going to have two semilunar valves, and then we're going to have our tricuspid valve here and our bicuspid valve here. Okay, so let's quickly mention real quick, because we're going to talk about the SA node and the AV node. The AV node, I'll do it right here, is approximately here, the AV node. And then the SA node, wait, atrioventricular, yeah, sorry, this isn't right. Here's our SA node and our AV node down here. So the AV node and the SA node, essentially, the SA node controls our autorhythmic cells, and the AV node is going to control the other types of cells that help control our heart rate. And then what we're going to have is these little bundle fibers that descend down here in the septum of the heart, and then they're going to branch over here, branch over here. These are called our Purkinje fibers. And these are the electrical cell pathways that the heart uses in order to send signals to the rest of the heart to tell it when and where to contract and how hard. So muscle cells, heart cells and muscle cells are quite different. And what we have with heart and muscle cells is, unlike skeletal muscle cells, they are able to contract on the bone. And so in muscle cells, that gives these muscles leverage for contraction, basically, like, for example, to like bend your bicep. Now, with heart cells, they're a lot different. And the reason these cells are different is because they don't have anything to pull on besides themselves. And so the way that they send muscles or send signals and the way they contract using each other is a bit different. And what we have here is two heart cells, and we'll use orange. And in between the heart cells we have, I'll just do it like this. That works, I guess. Okay, that orange we're going to call the orange, that intercalated disc. And the intercalated disc is a location for a few different types of cell junctions or gap junctions. And these intercalated discs are what connect the individual the individual heart cells to each other through cell junctions. In between the cell junctions or gap junctions are something called desmosomes. And desmosomes tightly connect the cell together. So what you'll have is essentially like this. You'll have a desmosome. And when the muscles, or when the cardiac muscle, when it contracts, the desmosomes pull against each other. So like there would be, like another desmosome here. And they have these little intermediate filaments. And these intermediate filaments are actually what bind, are connected to each other. And when these contract, that's actually going to cause the chambers of the heart to decrease. The gap junctions, these little guys right here, are what allow the signals, like the signaling cascades, to pass from one cell to the next. And one other important thing to remember is the arrangement of sarcomeres is different inside the heart cells than it is muscle cells. Let's see what else I need to remember. Yeah, so there we go. On to the next section. So yeah, like I said, we have our SA node up here, and we have our AV node down here. Then we have our left and right bundle branches, which this is like a bundle branch right here. And then our Purkinje fibers down on the bottom. These are our Purkinje fibers. The SA node is the pacemaker for the heart. And so the SA node actually generates the potentials that initiate contraction. And then they spread from the atrium into the ventricles and cause the heart muscle to contract. So anyway, let's move on to, so we're done with that. And we're going to talk about the two different types of action potentials. So first we're going to talk about cardiac action potentials. Let's draw one of these. This is going to be our time in milliseconds, and then this is going to be our millivolts. Okay, that's our threshold potential. And now what we're going to have is around negative 90 millivolts. You're going to have a little line that goes like this, and then it's going to shoot up extremely quickly to about here. We'll say this is positive 20 millivolts. And then you're going to see this slight dip. And it's going to kind of plateau and then drop like this. Okay, so each section has a different number. So I'm going to talk about each of the channels that open during this time and the purpose of each point in the cycle. So right here at number 4, this isn't, so when they count the action potentials, it starts at the peak of contraction, or I should say like the peak of depolarization. And so that's why this is labeled 1, and then it goes down progressively like this, 2, 3, and 4. And so here in Okay, so right here, this is the resting membrane potential for a heart cell down here, and it's a little bit lower than you'll notice at -90 compared to like -70 or -80 for other skeletal muscle cells. Now, cardiac muscles, it's super extremely important to remember that they are very permeable to potassium. And so during phase 4 of the this cardiac cycle for the cardiac cells, this is called IK1. The K stands for potassium. So this is just when the cell is at resting membrane potential due to its concentration of potassium. Next, in phase 0, we have the depolarization phase. And let's write this down. I'll just put it as DP for depolarization. What happens here is voltage-gated sodium channels. These voltage-gated sodiums, they open up, and when they open up, there's going to be a rapid depolarization through these voltage-gated sodium channels, which is going to drastically change the membrane potential of this said cardiac cell. And so when these voltage-gated sodium channels open to depolarize cells, these guys are going to close, and it's going to result in this massive uptick of polarization, or depolarization, excuse me. Then what you're going to see that's very different is just this kind of gradual decrease that happens in cardiac cells, whereas like in muscle cells, it's very drastic. And so the reason that is because here in phase 2, at this plateau phase right here, or excuse me, I'm getting ahead of myself. We'll come back to that. In number 1, this is rapid repolarization. So rapid, let's call it RRP, rapid repolarization, because at the end of this depolarization phase here, the inactivation gates on the sodium channel close. And that results in the ending of influx of sodium. So sodium's no longer going to come into the cell anymore, and we're going to start to see the cell start to repolarize back to its resting membrane potential. It's going to begin that journey downward. And transient outward potassium channels. Yeah, I remember that. And calcium activated chloride channels. So there's 2 different types of channels that are going to open here. Number 1 is the ITO1 channel, which is for calcium, and then the ITO2 channel, which is for chloride. And because there's these negative charge and this positive charge between calcium and potassium, that's why you're going to see the steepness of this curve not be as steep as compared to a skeletal muscle cell. Okay, yeah. So then we get to phase 2 here, and in phase 2, this is the plateau phase. And the plateau phase is really what distinguishes cardiac muscle from other excitable tissues in the body. And this is because the opening of voltage-gated calcium channels. This is why calcium plays such a large role in the cardiac cycle. So when these calcium channels open, they activate and inactivate much slower than sodium channels. So sodium channels are fast, and calcium channels are slow. And that's kind of why you see this gradual decline instead of a rapid decline. Now, when the so the calcium only contributes to the overall voltage of the cell until after the sodium channels respond. And so there's L-type and T-type calcium channels, and when in contrast to the calcium channels, okay, so sorry about that, Aaron. If you ended up pausing on this part, that'd be really embarrassing. But essentially, because there is this exchange going into the cell and out of the cell between calcium and sodium, that is what causes this plateau phase. So it's really hard for the cell to just decrease in polarization to get down to a negative 90 millivolts, because there's this exchange of calcium and sodium taking place. And then during phase 3, we have repolarization. And so during the plateau phase, more and more potassium channels open, and go towards the end of the plateau phase, the potassium channel efflux becomes greater than the calcium channel influx. And that is how the cardiac cell begins to repolarize. And the membrane becomes more negative, the calcium channels close, and some potassium channels open, and the membrane quickly returns to resting membrane potential. All the potassium channels close, and blah, 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 negative 90, resting membrane permeability to calcium. There's actually potential I've seen before. So something important to mention is, because there's this delayed repolarization of the heart cell, it helps the heart not contract too quickly again, because it won't be able to receive any additional action potentials during the absolute refractory period. And anyway, I think that is enough with that for now. Now we have action potentials. Let's change the size of this. And autorhythmic cells. So autorhythmic cells look a bit different. What we're going to see here is an increase, and we have decrease like this, and then an increase again. And increase like this. And this is going to be stage 4. 0, and 3, 4, 0, and 3, and 4. This is going to be when our funny channels open. We'll talk about that in a sec. This is our I calcium channel and potassium channel. All right, I'm gonna grab a drink real quick. All right, Aaron, I know this isn't perfect, but I'm trying here, bro. I'm studying. Okay. What you'll notice, especially here, is that there is no resting phase of these contractions. Threshold potential. So what you'll see here is that there are only 3 phases of action potentials for autorhythmic cells, and that once the membrane repolarizes, it quickly begins to polarize again. And so these there's a different cation channel that is only in autorhythmic cells, and these are called funny channels. And the reason they are funny channels is because they're called HCN channels. And funny channels are open when the membrane hyperpolarizes, and they also can be regulated by CAMP. And so the reason they call them funny channels is because that's the opposite way most channels work. Funny channels allow for sodium to slowly enter the cell, resulting in the gradual depolarization, phase 4. So this is depolarization, right? And then once you hit threshold, this is voltage-gated calcium channels, as you can see right here, and that's what causes that rapid increase in, or like the change in membrane potential. Phase 0. Phase 4, phase 3, phase 0. Yeah, so rapid influx of calcium is going to cause that phase 0 change. And then we have our T-type calcium channels, which are normally present in the adult myocardium. And both of these T-type and L-type calcium channels close slowly, or more slow than sodium channels, which is why you see this more rounded, wide tip. And it's just because the L-type and T-type calcium channels close more slowly than the sodium channels. And so what you would see is, for example, if somebody's heart rate was going to increase, the distance between this depolarization phase would actually shorten. And so what you would see is you would see the heart rate start to look like this. And just this distance being shorter is what's actually resulting in a faster heart rate. And that is because the cell is repolarizing faster. And so this is when you get something like, this would be sympathetic. So you have epinephrine or norepinephrine, and that's going to cause this sympathetic nervous system to activate, which is going to shorten that repolarization phase. And yeah, anyway, that's just kind of the tie-in there. So we've talked about here. Talked about. Okay, we'll talk about EKGs, I guess. Alrighty. So let's say we got negative here, positive here. Got our cells here. We've got our negatives here. Got our positives here. And what's going to happen is as our arrow, as the charge starts to move across the heart, because right, EKGs are what is picking up the charges as the cell is depolarized across the heart. Our arrow is going to move in this direction. As the wave moves through as the electric current moves through the heart cells, they are going to change in their polarization. And so at this point, before anything's happened, all the cells are at rest, and so all you're going to see is just a flat line. But what's going to happen is as the charge moves down, you're going to see these cells start to flip to negative, and these cells are going to become positive. And what you're going to start to see is this gradual increase in polarization. And so there's now a difference between the positive and negative poles between the inside and the outside of the cell. And this is what we're going to call our electric force vector. And the direction is determined by assessing which direction the depolarization is spreading. And then as we go further, we're going to start to see more of these get turned to negatives, more of these get turned to positives, more of these get turned to negative, more of these get turned to positive as the cell moves even further down. And what we're going to start seeing is just this increase in polarization. Now, the overall vector is not going to continue to increase. As you can see, there's still some positives over here and negatives over here. And because of that, you're not going to see just an increase, right? It's going to stop increasing because the vector can't continue to grow stronger, because now the poles are going to change and that vector isn't just going to continue increasing. So anyway, as this continues on all the way to the end, you're going to see the rest of these turn to negatives and these turn to positives, and then you're just going to see that overall vector start to dip. And so anyway, that is basically what's happening with an EKG on when you're looking at just one singular wave. That's kind of what the EKG is measuring. And so what we're going to get from that is something that most everybody has seen, and that is the standard. Actually, I'm not going to do it right there. Actually, it doesn't matter, whatever. The standard EKG. We'll do it in purple. So this is the baseline. Standard EKG looks like this. It's going to go flat. And you're going to have a little bump. And this is called the P wave. I'll write down here what's happening during the P wave. And so the P wave is generated during the depolarization of the atria. And so as the depolarization vector moves starting at the SA node, this depolarization is going to show up on the EKG, right, as these cells change in polarity. That's why you're going to see this little deflection, right? So this is measuring the depolarization of the cells in the atrial node, or in the atrial area, right, of the left and right atrium. Next, what we're going to see is something called the QRS wave, or the QRS complex. And so what's going to happen is you're going to see a slight dip in the depolarization, and then you're going to see a really sharp increase. Looks something like this. And then a decrease again, and then a return again to level. And I'll continue on in 1 second. So this is our QRS, or the QRS complex. And what's happening during the QRS complex is this is the depolarization of the ventricles. And what happens during the depolarization of the ventricles is there is going to be a contraction, which is going to allow blood movement throughout the heart. And then what you're going to see is the T wave. And the T wave looks like this. T wave is the repolarization of the ventricles. The T wave is generated during the repolarization of the ventricles. We do not typically see a repolarization wave for the atrium later because it is occurring at the same time that the ventricles are depolarizing. Okay. Okay, so anyway, I'm really bad at teaching this stuff because I'm probably going to bomb this test. But retarded, but whatever. Okay, so now we're going to talk about STEMI and NSTEMI. Those are referred to as abnormal current of injury. And essentially what that is you can detect on the EKG when an aspect of the heart is repolarizing or depolarizing at a different time or at a different rate than usual. So we're going to have two different things that cause that. Something that we call an NSTEMI or a STEMI. And so a NSTEMI stands for non-elevated myocardial infarction. And so compared to the normal one, what you're going to see so let's say this is a normal one. What you're going to see on a NSTEMI is something that looks a little bit like this. You're going to have a normal P wave, normal Q wave, normal R wave. And now at the S wave so this is also called ST depression. What you're going to see is instead of having a quick repolarization, it's going to kind of gradually return, and then you're going to have a big T wave, and it's going to look something like that. So as you can see, this S and this T wave, this S wave is super depressed, and I'll explain kind of why that happens. So the reason the non-STEMI happens is because all of the cells in the ventricle are depolarized, and so the cells are negative on the outward surface. So in the myocardium. Yeah, myocardium. And then there is, because we don't now have an area of negative, setting, we don't have an area of negative setting up a dipole, an area of negative setting up a dipole with an area at this point, what's still positive. So at this point, the ECG will try to draw a line at the original baseline. However, as the heart repolarizes, the repolarization will move past the hypoxic cells and leave them still negative on the outside after repolarization, but everywhere else is repolarized. So the ECG will sense a background current of injury again and gradually deflect upward to finish the T wave. This creates a shape recognized as an ST depression and suggests that there is an area of endocardium that is hypoxic. So usually what happens during these is the cells, so you have hypoxic cells, and that is because what the frick are they called? I can't even remember what they're called. Anyway, dude, how long is this thing already? I was trying to see how long the video was at this point. So anyway, there are vessels that supply blood to the heart, and if they get blocked, what's going to result is in cells that don't receive the nutrients that they need, and so they're going to start dying. And because they start dying, it's going to change how they receive. It's going to change how they receive signals, and so it's going to look vastly different on the electrocardiogram than normal. So this is going to result in a change. Which is going to change the look of the EKG. And now we'll talk about STEMI. So this is also called ST elevation. And the ST elevation is caused by an area of hypoxic cells that involves the entire thickness of the ventricular wall. So we have our heart. So with the ST depression, you only have an area of hypoxic cells that does not reach through the entirety of the endocardium. You only have a little portion of it. However, in STEMI, what happens is it's called a transmural infarction, and so the entire heart wall on this left ventricle is totally hypoxic. And so that area of ventricular wall is going to change the average vector, and it's going to move more up, right? So the average vector is now going to be heading in more in that direction, and that's what's going to elevate these S and these T waves. So they're going to look totally different than normal. And so the downward direction, so this direction is called our current of injury. And yeah, so that's just going to tell us that there's hypoxia that exists across the entire ventricular thickness. Now we're going to talk about something called entropy. So we're kind of going to move backwards here. So entropy. So entropy is just contractility. So just how fast the heart contracts. And the body has ways of controlling that. And so the main one way to change heart rate is through entropy. Sorry, I'm kind of jumbled all over the place. And that is essential, right, obviously, for our day-to-day living. If we have an increase in entropy, that's going to cause an increase in heart rate. And so when you're exercising, obviously you need contractility to increase so that you can increase your heart rate, which would deliver more oxygen throughout your body. And so the way your body does that is through the beta 1 receptor, which responds to norepinephrine. And epinephrine. And so when the beta 1 receptor is activated, it activates the alpha subunit of the G protein receptor in the cells. When that happens, something can respond to that, and these alpha subunits interact with calcium. And these increases the opening of these calcium channels. And then what happens is there is an influx of calcium into the cell, and the concentration of calcium obviously would increase because just, I don't know, makes very obvious sense. Because there's an increase in concentration of the intracellular fluid with calcium, the calcium-induced calcium released from the sarcoplasmic reticulum also increases, which increases contractility. Because now, with the increased amount of calcium that is present in the cell, that means there's more calcium that can bind to troponin, which can move troponin off of tropomyosin, allowing the myosin heads to bind, which, as we know from the last unit, increases contractility. Okay. That's one way it can happen. The heart can also increase once these alpha subunits do their job. These activate adenylyl cyclase. We're just going to put that as AC. Adenylyl cyclase increase, which also increases CAMP, cyclic AMP. We know that cyclic AMP, CAMP, activates protein kinase A. When protein kinase A is activated, there are 4 things that can happen. Protein kinase A we can have phosphorylation of, so these are all going to stand for phosphorylation. We can have phosphorylation of L-type calcium channels. We can have the phosphorylation of ryanodine receptors. We can have the phosphorylation of phospholambin, which is new to this unit. And the phosphorylation of troponin. Essentially, all of what these are going to do in different ways is increase contractility, which is what we call the inotropic effect. Next, we have the chronotropic. Which is the opposite of inotropic. And positive and negative chronotropy. Hey Google, define chronotropy.
According to Wikipedia, chronotropic effects are those that change the heart rate. Chronotropic drugs may change the heart rate and rhythm by affecting the electrical conduction system of the heart and the nerves that influence it, such as by changing the rhythm produced by the sinoatrial node.
Okay, so there you go. I just learned something from Google. Chronotropy is just the increase or decrease of the heart rate. However, I'm pretty sure this is just done through the parasympathetic activity. And then the sympathetic division of the nervous system only affects inotropy. So again, we're going to have beta 1 receptors. These are going to bind, increase adenylyl cyclase, which is going to increase CAMP, which is going to affect the funny channels, which is going to lead to an increase in sodium. The point is, if the catecholamines, so positive is catecholamines, we'll just remember that. Because I don't want to draw this entire chart out right now, because I got to do another one of these. And then these are going to be acetylcholine or cholinergic. So your catecholamines are obviously going to be your epinephrine and norepinephrine. And so if the rate at which the heart is beating increases, that means that it is responding to catecholamines, which is going to increase the beta 1 adrenergic receptor, increase adenylyl cyclase, increase CAMP, increase sodium, increase the slope of the membrane potential, which is going to increase heart rate. It also can do it by phosphorylating. CAMP can increase pKa, which increases calcium influx, which would increase it. However, if this is not done through a beta 1 receptor, let's say it binds to an M1 receptor, you're going to have the exact opposite effect, because these M2 receptors are going to be bound to by acetylcholine. And what that's going to do is there's 3 routes. The first one is the muscarinic receptors are going to activate a beta gamma receptor or heterodimer, an alpha subunit, or this is going to increase the GERK channels. This is going to decrease CAMP. And this is going to decrease camp. And obviously that is going to decrease the heart rate. So these are all going to decrease the heart rate. Blah, blah, blah. Where's that stupid thing with calcium? There it is. Okay. Let's talk about calcium. So calcium, very similar to skeletal muscle has T tubules. Then we're gonna have our little area of sarcoplasmic reticulum. RT tubule, blah, blah, blah. Start with this. So calcium affecting the cardiac muscle contraction. What we're going to have is an action potential. This is our action potential that enters the T tubule. When the action potential enters the T tubule, the voltage gated channels, the voltage gated calcium channels are going to open. So those guys are going to open. A little open. Calcium's going to rush into the cell, okay? All the yellow dots is calcium. In the cell. Okay, that's all our calcium in the cell. Voltage gated calciums are going to open and calcium is going to enter the cell. When calcium enters the cell, These are our ryanodine receptors. The calcium on the outside of the cell is going to come down and bind to the ryanodine receptor, which is going to open that channel and allow calcium to leave, which is going to come down here and affect our muscle contractility. And that is going to allow the troponin to initiate contraction, and relaxation occurs when the calcium unbinds. So it's going to unbind from the troponin, and the Circa pump is going to this is our Circa pump. It's going to pump the excess calcium back into the sarcoplasmic reticulum, and the calcium is going to be exchanged for sodium, 1 calcium for every 3. Wait a second. Oh, so it's either going to get pumped into, so then 4, 5. Relaxation occurs when calcium unbinds from troponin. 6, calcium is pumped back into the sarcoplasmic reticulum. 7, calcium is exchanged with, so this is going to be 1 out for every 3 sodium in. And the sodium gradient is maintained by the sodium-potassium ATPase pump. Oh, that's potassium. So yeah, anyway, that's how calcium affects the cell. All right, and now we are going to talk about this last thing. So we're going to talk about diastole and systole. Systole is the contraction of the heart. Diastole is the relaxation of the heart. Draw a little graph out here. Okay. Be pressure. Okay. So we're gonna have a little line that goes like this. And then it's going to, what the hell did it do that for? Okay, so now that you've stayed in tune for the last 10 minutes while I drew, this video is going to be like 4.5 hours long. So we'll just use orange. So this orange, this line right here that we're going to be talking about first is the aortic pressure. And so what we're going to see is as the first stroke of the heart happens, there's going to be an increase in pressure as the aortic valve opens and blood gets ejected from the heart. And then what we're going to have is there's going to be an isovolumic relaxation, which means the heart is no longer contracting and the volume is not changing. And then right here is where we have the dicrotic notch. And at the dicrotic notch, that's actually when the AV valve is closing. And so that little change in pressure is due to the fact that blood is pushing on the opposite side of the bicuspid valve as it's leaving the atrium, or excuse me, the left ventricle into the atrium, or into the aorta. So we have our systole here, our diastole here, and our systole here again. There's a couple other dotted lines I need to include here. Just kind of help break up different sections of the deal here. What else do we have going on? Anyway, yeah, the black line, aortic pressure. The blue line is ventricular pressure. Forgot another black line. It's gonna go something like this. Like that, that's ventricular pressure. This is ventricular volume. And this is the EKG, or ECG, and these are heart sounds. Anyway, so what you'll notice here is that during different stages of systole or diastole, there's going to be changes all across the heart. The diastole starts with rapid inflow of blood, and that's when the aortic valve is closed, and so there's going to be an increase in pressure. Then during diastole, this is the second third of diastole, there's very little change in the volume, and so that's kind of where you see this area of the dicrotic notch. Systole, there's an area of isovolumic contraction. The pressure begins to change, however, volume doesn't change. And then systole, the next part is you have ejection of blood from the ventricle into the aorta, and obviously the heart blood volume would change because blood is leaving the heart. And then the dicrotic notch is because the aortic valve produces a pressure wave and blood pushes against it, resulting in that little spike you see called the dicrotic notch. And yeah, so that's that. The heart sounds are all due to different points of the valves opening and closing. So the sounds you actually hear are the reverberations that take place as valves close. And that is why you are actually hearing sounds when blood is being pumped. So yeah,